Should we start?
Yes, sir. We can start. We can start.
Okay.
7:03
Okay.
already. Yeah.
Good evening, everyone, and we welcome you to our international speaker program here in on behalf of the PHO chapter. And it gives me immense pleasure to welcome Dr. Leo Mascarenhas, who is MD, MS in the division and the division chief and director of pediatric hematology oncology at SIDA Sinai Children's, and the director of the sarcoma program in Cedar Sinai in Los Angeles, California, where he is a clinical scholar and professor in the Faculty of Pediatrics and Medicine. Prior to this, he was a deputy director at the famous Children's Hospital, Los Angeles, where he held the Associate Sarcoma Program Endowed Chair and was the director of the Sarcoma and Solid Tumor Program. And he had an academic appointment at the Keck School of Medicine. Dr. Mascarenhas, I had the opportunity of meeting him in Westmead when he was traveling in Australia, and it was really good to hear. And we did a tumor board with him. He's an internationally recognized expert and clinical investigator in sarcomas and hepatoblastoma. His research has focused children, adolescent, young adults. He's the principal investigator of NCI-funded COG studies and the elected chair of the voting body of COG. He has many hats, wears many hats, and he also serves as a member of the Bone Sarcoma and Soft Tissue Sarcoma Scientific Steering Committee of COG. He has mentored so many residents and junior faculty at CHLA and other institutions, and has been honored by these special awards which the pediatric residents honored him with, which is the Philip E. Rothman Award for outstanding teaching, guidance, and inspiration, and by the Hemong Fellows and the inaugural Walter Long Award for inspirational teaching and guidance. He has lectured at the biannual board review course of ASFO and recently completed his second term on the board of directors of ASFO. He's an invited speaker to many conferences, and we actually requested him to attend and speak on one of the FOCONs, but somehow, the timing did not click, and we are very hopeful that he's going to join in one of the future FOCONs that the PHO chapter will organize. He has got more than 100 peer-reviewed publications, and, he's a medical celebrity in the field of sarcoma. So we are really looking forward to hearing about childhood rhabdomyosarcomas. So Dr. Leo, the session would be somewhere around 40-45 minutes. And, we generally have a room for an extra 5-10 minutes. And this is followed by question and answers, which we request everyone to just put those questions into the chat box, and we'll have the question session at the end, which Dr. Vinod and Dr. Badira will be conducting. So thank you so much for accepting our invite, and over to you now.
Thank you very much for that very kind introduction, and really honored to give this webinar. I have plenty of information to share, so I'm going to go at a fairly fast clip over here, and hopefully we'll be able to get through in about 45 minutes, so we have some time to speak. I'd just like to start, with some acknowledgements, and prime among that are my, acknowledge the support of my wife and daughters, my patients and their families. I've had the opportunity to work with so many outstanding colleagues in all different arenas. My trainees really inspire me, and a lot of the work which I'm presenting today, were done in the context of the Children's Oncology Group Soft Tissue Sarcoma Committee, and my funders are below, and I don't really have any financial disclosures to actually make. So the outline of this lecture is to describe the incidence and clinical features of childhood rhabdomyosarcoma, recognize prognostic factors in childhood rhabdomyosarcoma, understand the role of multidisciplinary care in the management of childhood rhabdomyosarcoma, and value the contribution of research to improving outcomes and addressing gaps in knowledge for childhood rhabdomyosarcoma. So this pie chart over here really shows the distributions of most of the childhood cancers, which are actually seen commonly in the United States. And you can see that rhabdomyosarcoma comprise about 3% of all cancers over here. Rhabdomyosarcoma takes its origin in Greek, where rhabdo means rod, which describes the cell shape. Myo is muscle, sarc is flesh, and oma is tumor growth. So fairly self-explanatory. It's the most common soft tissue sarcoma seen in children and adolescents. It accounts for about 50% of soft tissue sarcomas in children less than 15 years of age. It's the sixth most common childhood cancer in the US. And it's a really rare disease. And even for a population base of about 300 million, we see about 350 new cases a year. Rhabdomyosarcoma sort of has this bimodal distribution. And the SEER monograph, you can see, if you actually follow the blue line, there's a peak in the first decade of life, and then it drops, and then there's a secondary peak during adolescence in comparison to the other soft tissue sarcomas, which in childhood we call non-rhabdo soft tissue sarcomas, because they just become much more common in adolescence. And sarcomas in general continue to increase in incidence for the rest of life. In this sort of SEER monograph, you can see it's slightly more common in males. And again, you can see the majority of patients are really below the age of 20, below the age of 30. And after that, it becomes vanishingly rare. I mean, the oldest patient I've seen with rhabdomyosarcoma is 63 years old, but there are few reports of those who are actually older. One thing to note is the adult type, pleomorphic rhabdomyosarcoma is not really considered in the spectrum of childhood rhabdomyosarcoma, and I will not be addressing that during this presentation. So rhabdomyosarcoma can, really basically occur anywhere in the body. And these are pictures of my patients over the years. And, you can see this newborn baby over here was born with a large mass on his scalp. This guy over here with a large paratesticular rhabdomyosarcoma came in after running the LA Marathon, and he actually thought that he had a hematoma over there. And here's a teenage girl who had metastases to the breast. Sometimes they can be very, very subtle, like you can see over here on the and this tumor on the right hand of this patient, and the slight difference between both sides is really important. And the typical sort of grape-like experience of sarcoma botryoides when it occurs in the vagina of a young child. So rhabdomyosarcoma is actually, can occur as a manifestation of cancer predisposition syndrome. And the most common syndrome really associated with rhabdomyosarcoma is Lee-Fraumeni syndrome. And in this graph over here, you can see if you look at a population of Lee-Fraumeni syndrome and you have a patient with rhabdomyosarcoma, has the highest incidence very early in life. And most of these are fusion-negative rhabdomyosarcomas, and then it drops when osteosarcoma becomes the more common sarcoma. But when you look at sporadic rhabdomyosarcoma in the bottom of the graph, you can see that the incidence is actually fairly low compared to the other types of sarcomas. So how does rhabdomyosarcoma present? It's really quite simple. It's a mass with or without pain, or with or without disturbance in function. And you can see the distribution over here. Over a third of rhabdomyosarcoma is seen in the head and neck, and those are orbital tumors, other head and neck tumors, and the parameningeal head and neck tumors, which are a distinct group. So just to make sure, the definition of parameningeal is that the tumor has to abut the base of skull. If it doesn't abut the base of skull, it is not parameningeal, and it's considered a head and neck primary. Then a large number of tumors on the genitourinary system, and this includes all the genitourinary organisms, but quite rare in the kidney. But more common in the bladder, prostate, uterus, broad ligament, and vagina and cervix. And they can also occur in the extremity. But rhabdomyosarcoma can occur at any site in the body, and there is this distinct entity called rhabdomyosarcoma of bone, which was the last area. But that's not really a rhabdomyosarcoma. It's really a fusion-driven sarcoma, which has some features of rhabdomyosarcoma and is misclassified, and again, shouldn't be considered rhabdomyosarcoma. The most common pattern of spread is lymphatic, and it's actually quite common in the paratesticular tumors and extremity tumors. Then hematogenous, where they primarily metastasize to the lung, bone, or bone marrow. But just last week, I saw a patient who came from New York to see me, and that patient actually had a metastasis to the intraluminal wall of the ascending colon. So it was the first time I've seen that, but any of that can actually happen, and so you just have to be vigilant. Then parameningeal tumors, about 50% of them have CNS extension, and to define CNS extension, you need to have a cranial nerve palsy. You need to have erosion of the cranial bone or direct intracranial growth. And sometimes it can be as subtle as dural enhancement in the particular area, which will give you the indication of that. So this is the staging system which we use for rhabdomyosarcoma, which is a little complicated, and it's a modified TNM staging, which most of you may be familiar with. But this is fairly complicated. And so over the years, I've sort of distilled it down to these sort of things, to just make staging easy so that you could refer to this. So stage 1 is any tumor which arises in a favorable side, irrespective of size and lymph node involvement, provided they don't have distant metastases. And what are favorable sites? Favorable sites are head and neck non-parameningeal, genitourinary bladder prostate, are really, and previously biliary was considered a favorable site, but it's no longer considered a favorable site. So that has actually drifted over the years. Then the next thing to think about is if a patient has distant metastases, those are automatically stage 4 patients. And different from Wilms tumor and some of the other pediatric cancers, if you have a malignant effusion with ascites, pleural or peritoneal nodules, and malignant cells in the CSF or diffuse leptomeningeal involvement, it's stage 4 disease. So it really comes down to distinguishing between stage 2 and stage 3 tumors. And so any tumor with regional lymph node involvement arising in an unfavorable site is stage 3. So that leaves the remaining tumors, which are small tumors, less than 5 centimeters or less, arising in an unfavorable site. And those would be stage 2 tumors. And why is staging important? Because if you really see these Kaplan-Meier graphs over here, survival, event-free survival is clearly associated with stage, with stage 1 tumors doing the best and stage 4 tumors having a poor prognosis. So these are my sort of staging pearls, which especially if there are any sort of fellows or trainees on parameningeal, if you have intracranial extension, that does not make you high risk. And so if you go into ChatGPT and you put it in, the most common mistake you'd see is that they call intracranial extension high risk, but they're not really high risk tumors. Extremity tumors in general must have ipsilateral lymph node sampling, because this actually, the incidence of occult metastases is at least about 30%. And radiation to the regional lymph nodes might make a difference. Similarly, for paratesticular tumors, we recommend ipsilateral lymph node sampling. Previously, it was a dissection. Now it's just sampling. And this can be avoided in boys less than 10 years of age if a thin cut CT scan is done. But even if the CTs or PET scans are negative, the recommendation is to actually do lymph node sampling in those older than the age of 10, because occult metastases is found in about 30% of patients. And if you look at the IRS-4 data, those patients, instead of having a expected survival of over 90%, really had a survival in the 60% range. And then in orbital tumors, if you ever see alveolar histology, in my opinion, it's not an orbital tumor. It's really a parameningeal tumor. So you should really go back and look at the scans well. And so it's a parameningeal tumor which is pushing on the orbit and presenting as proptosis. So when you're staging a patient, we generally recommend an MRI or a CAT scan of the primary site, a CT scan of the chest, a bone scan, and bilateral bone marrow aspirates and biopsies, with a spinal tap for patients who have parameningeal tumors, especially those who have leptomeningeal enhancement and intracranial extension. Some people use PET scans, and PET scans are good also for staging. And if you do that, you don't really need to do a bone scan, but they are not as sensitive for bone marrow involvement. But colleagues in the children's oncology group really did an exercise over here to see, especially, and this may be important if you are resource limited and you don't have the ability to do a complete workup. And so maybe you look at all patients with the diagnosis of rhabdo, and basically, if you have lymph node involvement, then you need to do the entire sort of staging workup. If lymph nodes are negative, the next thing is to look at the tumor to see if it is invasive or not invasive. And if it's not invasive, you don't need to do a further workup because those are likely embryonal tumors and the group 1 tumors. If the tumor is invasive, then you go ahead and it's based on histopathology. And if it's favorable, which means embryonal and fusion negative, you can do a CAT scan of the chest. And if the CAT scan of the chest is negative, you can stop with the workup. But if the CAT scan is positive, then you do the rest of the workup. Similarly, if you have if the molecular pathology is either alveolar histology or Fox or has the fusion, then you can go ahead and do the full workup. So to make things more complicated, we also have what's called the IRS grouping. And for IRS grouping, it's really determined on the extent of surgical resection at the time of original diagnosis. And again, to avoid this complication, over here, I've sort of simplified it on this slide. So group 1 is after the surgeon takes it out and there's no evidence of gross or microscopic disease. And so that's called an R0 extension. So I'd usually joke and say if the surgeon says he takes it out and the pathologist agrees with him, then that's group 1. Group 2 is if the surgeon tells you he's taken out the tumor, but the pathologist says, oops, no, I think the surgical margins are positive. Those are R1 resections, and those are group 2. Group 3 are patients who have gross residual disease. And those are patients who just have a biopsy or a partial resection. And a majority of rhabdomyosarcoma, because of where they are located, tend to have group 3 disease, at least about 50% of them. And group 4 are patients who have distant metastases. Why is grouping important? For the same reason, staging is important, because by group, you can see group 1 patients have the best prognosis, while group 4 patients have the poorest prognosis. So the next important thing to consider is embryonal histology, which is seen about 60 to 70% of cases. It simulates immature muscle. And if you look at this photomicrograph on the left-hand side, you can see these little pink processes, these large cells. And those are rhabdomyoblasts with some striations come in. And they express muscle markers in immunohistochemistry. And there are some variants with botryoids expected to be more favorable. And the spindle cell, if you don't have a MyoD1 mutation, those are actually favorable tumors. And then the solid variant. But we don't really distinguish most of them in this day and age, especially when we have access to molecular analysis. The other big group of tumors is alveolar rhabdomyosarcoma, which is named just because it's these solid sheets of blue cells which really form these little nests over here, which recapitulate alveoli in the lungs. The reason they're called rhabdomyosarcoma is because they actually express the muscle markers by immunohistochemistry, and they are uniquely associated with these balanced translocations between 2 and 13, and less commonly in 1 and 13, and actually quite common in the extremity as a primary site. In fact, the majority have alveolar histology. And then if you have lymph node and they have a higher chance of lymph node involvement and a poorer prognosis. So if you actually see embryonal histology in the extremity, it's almost always associated with anaplasia. And those are the patients who tend to have a germline P53 mutation. And so they may be index cases for Li-Fraumeni syndrome. So why is histology important? It's because embryonal, spindle, and botryoid histology do the best, and alveolar histology for patients with localized disease have a more intermediate prognosis. This is a little cartoon and the karyotype of a balanced translocation between chromosome 2 and 13, which was first associated with alveolar rhabdomyosarcoma for the first time in 1987. And this is again a cartoon showing, the fusion of the transcription activation domain and the regulation domain between the PAX3 and FOXO1 fusion for the more commonly seen 213 translocation versus the PAX7 FOXO1 fusion for the 113 translocation. And this is important because the PAX7 fusion tends to have a slightly better prognosis than the PAX3 FOXO1 fusion. So why is histology and fusion status important? If you can again see from these Kaplan-Meier curves over here, you can see that patients who basically have fusion positive disease don't do as well as patients who have fusion negative disease. And this is actually irrespective of histology. So if you look at these Kaplan-Meier curves, it's better seen on the right-hand side. If you actually look at these patients over here who are fusion positive, you can see their outcomes versus the alveolar fusion negative and embryonal patients who have similar outcomes in this cohort of patients. So a risk stratification for rhabdomyosarcoma includes staging, grouping, and used to be histology, and now we no longer do histology, and we usually just use fusion status in risk stratification. And this is the present risk stratification for the children's oncology group, where if you have for low risk, these patients are patients who are expected to have an overall survival of over 90% and an event-free survival of at least 85%, you can see that they all occur at favorable sites. So they're stage 1, or if they are unfavorable tumors which arise at an unfavorable site but are less than 5 centimeters and do not have lymph node involvement, and if they've at least had a gross resection at any age, which is a little different from the European classification where age is taken into consideration. The high-risk patients on COG are any stage 4, group 4 patients who are fusion positive, and those who are greater than 10 years old who are fusion negative, because in our experience, these patients who are fusion negative and less than 10 years old, even if you have stage 4 disease, their prognosis is very similar to the intermediate risk patients, which comprise all the other patients. So what is the treatment of rhabdomyosarcoma today? It's really surgery, radiation, and chemotherapy. And these sort of bubbles, which I put them in, really indicate the importance of each thing. That, in order to be cured of rhabdomyosarcoma, you must receive chemotherapy. Radiation therapy, because of the varied sites and the morbidity associated with surgery, is more commonly employed for local control. But of course, since it's in young children, it's a bigger problem. And sometimes surgery is appropriate. So what's the role of surgery? It's excision of the primary tumor upfront whenever possible without causing major functional or cosmetic deficits. And the reason for this is if you become group 1 or group 2, you have the best prognosis in these patients. And so therefore, very often, you might find a patient who has what we call a whoop surgery. So somebody out in the community resects a lump, and then the pathology comes back as rhabdomyosarcoma. If it's soon enough and there's been no progression, primary re-excision of the tumor, if feasible, really should be undertaken. We've already spoken about ipsilateral lymph node sampling and lymph node for paratesticular and extremity tumors. And then second look surgery is sometimes used to avoid the morbidity of radiation for fusion negative tumors. The role of radiation therapy, in general, when we looked at IRIS-4, which was, really the biggest rhabdomyosarcoma study, we call it the mother of all studies, was basically, when radiation therapy was used for local control, the majority of recurrences were local recurrences, and then followed by regional distant recurrences, and then regional recurrences. We usually don't give radiation therapy to fusion negative, so those are embryonal tumors or alveolar tumors without the fusion, who are group 1. Radiation usually spans anywhere between week 3 and week 18, but in general, we prefer to administer it after 12 weeks of surgery. Delaying radiation beyond 18 weeks of therapy has a pretty high risk of a local tumor progression. And the doses used are anywhere between 3600 to 50.4 centigrade. And efforts to escalate dosing either by of radiation therapy for large tumors as well as by hyperfractionation have not been successful and have not improved the outcomes of patients. Rather, they've increased late effects. So why is radiation important? I mean, because, you can see from this, it's pretty impressive in controlling local disease. And this is from IRS4 based on site, where the local control rates were above 80%. So chemotherapy, obviously, the role is local and systemic tumor control. It's multi-agent and intensive. In North America, the standard chemotherapy is vincristine, dactinomycin, and ifosfamide. In Europe, the standard therapy is vincristine, dactinomycin, and ifosfamide. But there are many other active agents, including irinotecan, topotecan, doxorubicin, etoposide, and ifosfamide. So just quickly, with all these treatments, however, there is a cost. And you can see over here in long-term survivors on the CCSS study, where you compared survivors of childhood cancer compared to their siblings. These are the risks of toxicity, grade 1 through 5 total, where almost 70% of long-term survivors have some sort of late effect, and 40% of them have a grade 3 to 5, which means they are very serious and require medical attention. And when you look specifically at soft tissue sarcoma, you can see a similar sort of pattern. And then when you look at long-term morbidity, again, when you compare that to the siblings, so this is the process of normal aging. As you get older, about 20% of people who are 50 years of age who don't have a history of cancer have some sort of medical morbidity. But when you look at survivors of childhood cancer, over 50% of them have a serious medical problem. And this trend is the same for soft tissue sarcoma. Just note that the axes are slightly different over here. So coming to what have we learned from clinical trials broadly, I mean, this is a really good review of all the IRS studies, which was actually performed. And if you haven't read it, it's a good source of information. We started doing cooperative groups in the United States in the early 1970s. And then now we are in the next series of the ARSTs, which I'll discuss later. But this really sets the background of today's clinical trials. And you can see that with doing these trials, we've successively improved outcomes for patients with rhabdomyosarcoma. But the amazing thing is, with all these studies from IRS1 through 4, we didn't have a single positive randomized clinical trial. So it's really by fine-tuning, staging, better supportive care, and careful collection of data that we've actually made these outcomes and better outcome. The next trial after this IRS4, which was done, was the randomization in intermediate risk patients of vincristine, actinomycin, and cyclophosphamide to vincristine, actinomycin, cyclophosphamide alternating with vincristine and irinotecan. And as you can see, there was no difference in the new regimen. And so they picked the VAC-VI regimen as being better. The challenge with this particular study is, if you look at the event-free and overall survival with this regimen, they were about 10 points lower than IRS4, though this regimen was less toxic. And the important thing to remember in rhabdomyosarcoma, your salvage rates are almost zero and come with a high risk of morbidity. And so subsequently, when we looked at all our outcomes for trials done in the ARST series and the D series from 1997 to 2013, you can see that the EFS again remained in the low 60s and the overall survival, close to 75%. So really saying that we haven't moved the needle, which probably means that we have reached a plateau of what we can achieve with surgery, chemotherapy, and radiation. And we really need to do something different. The outcome for patients with metastatic disease is terrible and continues to be terrible. And every intervention which we have made has not really improved the outcome of these patients. And I've put this sort of, a bar diagram together to really, with all the clinical trials which have been done, and the red and green panels are for patients with localized disease. And you can see over here, event-free survival in red, overall survival in green, that with time, it actually improved all the way up to IRS-4. And then it sort of began, the event-free survival began to drop, though overall survival was maintained. And what this tells you is that more intense therapy actually improves the relapse-free survival of patients with localized rhabdomyosarcoma. Conversely, with stage 4, group 4 disease, it's remained relatively flat. And the more recent series, you can see overall survival has improved without a significant improvement in event-free survival. And this may be due to access to new clinical trials for these patients, which just sort of extends their life, but doesn't really sort of cure them. So coming to this other group of adult rhabdomyosarcomas, and this is an interesting paper where they actually looked at those over the age of 19 in Italy. And what they saw was if a patient actually received all the treatment which they were supposed to receive, similar to childhood rhabdomyosarcoma, their outcomes were actually not that bad. They had an event-free survival of 61%. But the majority of adults, something was missing somewhere, and they actually had a poorer outcome. And so when we looked at this information in the SEER data, which you can see over here, you can see that when you look at the difference in survival between children and adults, and these are highly significant, there's a higher survival in localized patients versus, if you're a child or an adult. There's a slightly higher incidence of tumors arising in an unfavorable site. You can see that more patients were treated with radiation therapy, and then there were more patients who did not receive any local therapy in adults. And so some of these differences may contribute to the differences in outcome, but it may be a little more complicated. A big challenge is that a lot of oncologists think that adults don't handle chemotherapy as well as children. But when you actually look at the data, it's actually not true. Most of the toxicities are actually worse in children, other than peripheral neuropathy, secondary to vincristine, which is much worse. In fact, children have higher degrees of myelosuppression as well as mucus. The children have a higher degree of mucositis and as well as myelosuppression. And actually, adults tolerate chemotherapy from the hematopoietic standpoint a lot better than children. And in this, so we tried to see, what if the older patients enrolled in clinical trials, because we assume that they are actually going to get exactly the same treatment. But when we look at their outcomes, so patients less than 15 years of age compared to patients who are greater than 15 years of age, there's a highly significant difference in outcome between both children and adults. And I think this tells us that there's something different about the biology in these patients, and we really need to address that. Coming to relapse rhabdomyosarcoma, one of my mentors told me, the best thing is don't get cancer. And the second best thing is if you get cancer, don't relapse. because once you relapse, your outcomes are really terrible for most cancers, other than some germ cell tumors and perhaps now leukemia with the advent of CAR T cell therapy and blinatumomab. But in general, relapse cancer is really outcomes have not improved too much. And so we ran a clinical trial where we studied two different schedules of irinotecan based on preclinical models. In this, where irinotecan was given over 5 days on regimen A versus 10 days, because it looked like 10 days was much more efficacious, but obviously more than patients. And you can see from this graph, there was no improvement in outcome. So we had sort of reached a dead end, and really didn't know which way to proceed and try to improving the outcome of these patients. At that time, there was, we came into the advent of sort of molecularly targeted therapy, and there were very few drugs, which were potentially available who had completed early phase trials in pediatrics. And so one of the big drugs, as all of you all know, was bevacizumab or Avastin, where which targeted VEGF. And if you look at VEGF expression in rhabdomyosarcoma, you can group the high expressors into really those who have a poor prognosis, while intermediate and favorable were all over the place. And then the other drug which we had access to was temsirolimus, which was an mTOR inhibitor, and the famous PI3 AKT mTOR pathway, which really affects everything downstream in the cancer cell. And when it's dysregulated, you can get an increase in cancer cell growth, survival, division, and angiogenesis. And this was complemented with data from the pediatric preclinical testing program with rapamycin, which was an mTOR inhibitor, where you can see in these mice, when you combine rapamycin with vincristine or with cyclophosphamide, you really had mice which survived a long time or were inhibited, where the xenografts were inhibited completely. So this formed the background for us designing a clinical trial, which I was very privileged to lead, where in first relapse rhabdomyosarcoma, we gave all patients a chemotherapy backbone of vinorelbine and cyclophosphamide, and intravenous cyclophosphamide, and randomized them to receive bevacizumab and temsirolimus. And this trial had to enroll about 100 patients. And after about 87 patients were enrolled, I got a call from the study statistician who told me to sit down. And when I sat down, he said, "Your trial has been suspended effective immediately." And my heart dropped, because usually when they tell you that, it's because of something bad happening on the trial. But actually, it was because of a good thing, and that they actually saw very early on that patients who were randomized to temsirolimus did significantly better compared to patients with arm A. And so this gave us something to improve the event-free survival of first relapse patient with a very well-tolerated regimen. But more importantly, it helped us pick targeted therapy, which we could then move up to newly diagnosed patients. Unfortunately, the overall survival and event-free survival at 2 years continued to be poor, but the difference in event-free survival between the temsirolimus and the bevacizumab arm remained and was highly statistically significant. So what about maintenance therapy? This famous paper, which was published in 2019 by the EPSSG group, really looked at a group of patients whom they call high-risk rhabdomyosarcoma, who were randomized to receive maintenance therapy with vinorelbine and oral cyclophosphamide. And in this particular study, patients at the end, and these patients really form the COG intermediate risk group to the most extent, but not completely, and are generally more favorable on the COG side rather than being high risk. And there was no difference in overall survival, but there was a significant difference in overall survival but there was a trend towards that, and this was just recently updated earlier this year, where now they have a statistically significant difference at 10 years. The important thing to pay attention in this data is that this data is not from the time of diagnosis, and there's an attrition of almost 50% of patients from the group. And so it's a select group of patients who attain complete response with intermediate risk and without lymph node involvement, who might benefit from maintenance therapy in the context of the European therapy. And so when you compare the COG regimens and EPSSG maintenance, some similarities come up. The COG, even if it uses no maintenance therapy, the duration of therapy is generally longer, is generally longer than their standard chemotherapy. So one could argue it was the length of therapy which really made the difference for the EPSSG patient, because the vincristine doses were not there. The second thing is that vinorelbine is one of the best drugs for rhabdomyosarcoma at the time of relapse. And so they use this drug up front. So using a new drug may have also contributed to this. And when you look at the best outcomes in the COG studies, the alkylator dose was significantly higher. But when you look at the outcomes between the last COG study, which was completed, and EPSSG, the alkylator doses were similar. So based on selecting temsirolimus and those results of the maintenance study, we had originally designed a study of VAC-VI versus VAC-VI randomized to temsirolimus, but then this data of maintenance therapy came up, and we knew that this regimen was inferior to the previous regimen, the chemotherapy regimen. So therefore, we tagged on this maintenance chemotherapy to both arms of the trial, which sort of muddied this trial. And you can see in the outcomes over here, the results on this trial, and this is only at 3 years, and we traditionally report 4 and 5 year event-free survival in these patients. I think I'm coming close to the 45-minute mark, but I have a few more slides. Is it okay if I go on?
Yes, absolutely okay. Don't worry. Yeah, please go on.
So you can look that there was no difference in the outcomes over here, and these outcomes were very similar to the previous trial, which did not use maintenance and did not use temsirolimus. So our interpretation from this data is that overall, maintenance therapy doesn't really benefit our group of intermediate risk patients. And so I think the important lesson over here is not to mix and match. So if you choose, you're going to treat your patients with the EPSSG based therapies, stick to the EPSSG therapies. If you're going to treat them with COG therapies, treat them with the COG therapies, but don't mix and match, because it really may not mean that you're actually helping your patients. So this is the grouping of on the EPSSG side from the European group is much more complicated, because they take into account lymph node status separately and the age of the tumor. And so patients less than 10 years of age are considered favorable. And any patient who has lymph node involvement is considered high risk, which is the opposite. And the very high risk patients are those who have unfavorable histology with lymph node involvements, and then they classify metastatic separately. And here are their treatments. The very, very low risk group gets VA for 8 cycles. Then the others get IVA followed by VA in their standard risk, which is mostly the COG low risk group of patients. And then the high risk, which is largely intermediate risk group patients in COG, get IVA plus maintenance. And even though maintenance has not been shown to improve outcomes in metastatic patients, because they don't want to treat patients less aggressively than their high-risk patients, they just tag on this maintenance therapy for those with the addition of doxorubicin. And you can see these are overall survival, not event-free survival curves for non-metastatic patients with their treatment regimens. The event-free survival curves are not as good. Sorry, this slide was misplaced, late effects. And so after IRS-4, this is the summary of what we've done in COG. We tried topotecan, irinotecan. We tried to decrease cyclophosphamide multi-drug therapy. We tried earlier radiation, more radiation. We included proton therapy, and we also discouraged delayed primary accession. But the best results were really with the D series, which randomized VAC versus VAC VTC, but they had higher doses of cyclophosphamide, and the EFS on those studies was between 75 and 76%. So we decided where to go over here. So we looked at all the data with vinorelbine, and we saw that vinorelbine actually had a higher response rate for alveolar histology compared to embryonal histology. And we said that metastatic patients tend to have alveolar histology. So can we test this drug in metastatic patients? And so we designed the study which was with lower dose cyclophosphamide, vincristine, actinomycin, but the randomization of the vinca alkaloid was between vinorelbine and vincristine. And the days which they didn't get vinorelbine, they got vincristine in this trial. This trial has completed accrual, and we are waiting for the results, which we hope to get in the next 6 to 12 months. The important thing over here is that for the first time, we will see how metastatic patients are treated with lower dose alkylator agents fare, whether it's a bad thing or is it exactly the same as using a high dose therapy. And if it's the same as the higher doses of therapy, then this is a much more tolerable regimen for patients who are not going to survive long. So then we have this paper which came out, which is the genomic classification of rhabdomyosarcoma, which was a combination of COG and UK data. And I was really privileged to write editorial on this in the Journal of Clinical Oncology. And what they showed in this paper was that if you had a MyoD1 mutation, you did really poorly. If there was a P53 mutation in the tumor, you did poorly. If there was MYC amplification, you did poorly. And if there was CDK4 amplification, you also did poorly. So in an attempt to improve outcomes for low-risk patients, because, we cure generally close to 90% of them. So, but what are those 10%? Maybe those 10% of patients were patients who actually have one of these unfavorable characteristics. So on this study which is chaired by Dr. Hadong, and the vice chair is Dr. Venkatramani, we enroll these low-risk patients, and they have no unfavorable features, and they are very low risk. They only get 8 weeks of vincristine and actinomycin. If they do have positive margins and have gross disease, like the orbital primaries, they get cyclophosphamide for 4 cycles, followed by vincristine, actinomycin after that. And if they have unfavorable histology, they come off this and they get more intensive therapy. And that study is still enrolling patients. And so for intermediate risk, the optimal dose, there are a lot of people who still treat their patients with lower dose cyclophosphamide compared to higher dose cyclophosphamide. And you can see the difference in this. And so our next planned study, which really got approved, will address this question. And you can see the difference in event-free survival and overall survival between high-dose and low-dose cyclophosphamide. And you can see that there was an increased risk of local failure in those patients who had group 3 disease when the dose of cyclophosphamide was reduced. And when you compare the low-risk study, when they backed off of cyclophosphamide in the patients who were group 2 at favorable sites and 3 with residual disease, those patients actually had a poorer outcome, which was previously published. And so this new trial will then randomize patients to the D9803 regimen versus the VAC-VI regimen, which includes maintenance therapy. And this is the new EPSSG risk stratification. And they have a large and ongoing study, which is a very complicated study right now, which has one phase 1 study for the relapsed patients, and they have 9 randomizations with four chemotherapy questions, where they are looking at a novel regimen of irinotecan together with IVA versus IVA-DO for the high-risk patients, irinotecan plus IVA versus IVA alone for the high-risk patients. And then they're increasing the length of maintenance therapy from 6 months to 12 months for the uh, high-risk patients, a randomization, and for the very high-risk patients from 6 months to, it's from 12 months to 24 months. And then they're also doing a radiotherapy question where they're randomizing high dose to low dose and radiation of metastatic sites. So my main questions right now are with rhabdomyosarcoma, are there patients where we can limit morbidity? How can we pick which drug to study? In which group of patients can we study them most efficiently? What is the best method to study them? And what about tumor heterogeneity? And I put this up here as an example with targeted therapies, where you can see in these xenografts, if you use small interference RNA to inhibit integrin-linked kinase, in ERMS, the tumors actually grow, while in alveolar rhabdomyosarcoma, they shrink. So not all rhabdomyosarcomas are the same. So what will the future look like? I think you have a cancer diagnosis, you have a genome analysis, and then you have to make a clinical decision. So what's the role of personalized medicine? And when you look at this, it's not that easy. So our poorer prognosis patients, who are the fusion positive patients, they're the least genetic complex. But when you see the patients who actually do well, they are highly genetically complex and can have numerous targets. And so it's a little challenging, where we have more opportunities to target therapy in the favorable patients rather than the unfavorable patients. And so I think in the United States now, every single patient is tumor profiled through a trial. And then we are trying to study all these where we look at tumor heterogeneity and evolution, and look at both somatic, molecular, as well as methylation profiles in these patients, and see if germline variants really affect outcomes in these patients. And so the four main priorities right now for us are to identify novel agents by forging collaborations. You're really planning our studies so we learn the most from every single patient who's enrolled. Try to make our clinical trial design efficient because we have only a few number of patients. And then really, I think for those who do well, we really need to limit toxicity, because when we cure these patients, rhabdomyosarcoma patients have a very high risk of late effects. And this is a picture. And I think the message over here is today, cancer is about living. We have plenty of work to do, and all of us should continue to work hard to help these children do better. With that, I'll stop, and I'm happy to take any questions.
Thank you, Dr. Leo. It was a very clear talk. You started from the very basics of RMS and took us till the recent advances in a very elegant manner. So I'll just read out the questions, few questions in the chat box. So the first question from Dr. Swaminathan is regarding the difficulties in local therapy in infants and their outcome.
Yeah, I mean, that's a challenge. And so if you look at the Europeans, if you're less than 1 year old, those patients have um, a less favorable outcome. And so there are a couple of things in certain situations which might help, and that is to see if you can, number one, see if surgery is feasible, and if possible, do surgery. The other thing is not cutting back on the dose of cyclophosphamide, because especially if you do have microscopic disease and are not willing to deliver radiation therapy, then the high dose cyclophosphamide is actually beneficial. And I think the last thing you can consider for infants is to delay. That's the one group where you could delay radiation therapy. Maybe pushing radiation therapy till they are older than 1 or 2 years is probably what people will do. But again, those are associated with devastating side effects. And that's one of the reasons why infants continue to be, to have a poor prognosis. Having said that, sarcoma botryoides, orbital tumors, and things like that can be managed. And if you have a really talented surgical team, there may be opportunities for these patients. And this is one group where you could consider amputation if it's an extremity group, because children actually adapt a lot better. And from a young time, they figure that the challenge is it's often not acceptable to parents and looking at that. Yeah. It's not the best answer, but you're just sort of doing the best of what you can.
Thank you. Thank you. So the next question from Dr. Maharshi. A case of orbital rhabdo infiltrating paranasal sinus. Would you consider to treat as intermediate or low risk?
So that if it's infiltrating the paranasal sinus, to me, it's a paranasal sinus tumor infiltrating the orbit. That's a parameningeal tumor, and it absolutely should be treated as intermediate risk. Those are not low-risk tumors. They are misclassified as orbital tumors. Orbital tumors are very favorable tumors. They are almost always fusion negative or embryonal histology, and they are not invasive tumors. They don't extend past the bone, but they can present with very prominent proptosis. So if you see paranasal sinus involvement, it is a parameningeal tumor and it's intermediate risk. Unless the patient has metastatic disease, then it's high risk.
Great. Next from Dr. Virendra Patil, a 5-year-old kid with isolated intramedullary alveolar RMS, fusion negative, INI1 retained. What would be your approach?
Intermedullary, what do you mean by that? In the bone marrow?
Intramedullary. Dr. Virendra, can you unmute yourself? And
spinal cord. So, I mean, that's CNS rhabdomyosarcoma is particular rare. I mean, I think the most important thing is if the patient has leptomeningeal disease, I mean, I think the patients, even with their best of therapy, it's unlikely to be cured. I think depending on the age of the patient, you could pick either the COG regimen and treat with radiation therapy in that area with a higher dose cyclophosphamide, or if you're treating with a European regimen, I think you could consider the IVA-DO regimen. I don't know if there's any data, but some people believe Doxil has better penetration compared to doxorubicin, but the dose is a little lower, and of course there are some infusion side effects. That may be a consideration. And because they are very high risk, I mean, this may be a group of patients where you may think of continuing with maintenance therapy. But if the patient actually has leptomeningeal disease, unfortunately, I don't think the patient's going to survive long and will progress rapidly. So thinking about palliation may be important. Those are extremely rare. I mean, I think I see a lot of rhabdomyosarcoma, but I've seen about 2 or 3. And I would probably also get the diagnosis reviewed by an expert. I mean, you said no leptomeningeal involvement. So that's a little more favorable then. But radiation would be primary. And maybe this is a patient where you should start radiation sooner rather than later.
Great. The next question is to just discuss about the timing of radiation.
Yes, so in the past, people got really worried about cranial nerve involvement or intracranial extension, and they used to recommend radiation early, starting as, at the time of diagnosis with chemo. But radiation, to actually set up radiation takes some time, especially if you're using RT and things. And again, radiation doesn't work as fast as chemotherapy. So in those patients, I recommend starting chemotherapy as soon as possible, sometimes even without waiting for a diagnosis, as soon as you do the biopsy. It's very reasonable to start a patient on vincristine, actinomycin, and cyclophosphamide and for 1 cycle, and then if it comes back a different diagnosis, you can switch. The most likely different diagnosis sometimes is a Ewing sarcoma or other type of soft tissue sarcoma, and you can always switch therapy because vincristine, actinium, and cyclophosphamide are active in Ewing sarcoma, and if it's an other adults type soft tissue sarcoma, those agents have activity, but then you'd switch to doxorubicin and ifosfamide if it wasn't a rhabdo, and if on rhabdo, you're on the right path. The only thing we generally now recommend radiation therapy starting with the 5th cycle of chemotherapy. So after 4 cycles are completed, concomitantly with the 5th cycle of therapy, we recommend, if you have a metastatic patient, we recommend local regional radiation at week 13. Radiation to metastatic sites selectively, or whole lung radiation, depending on thing, at the end of treatment. Because if you radiate metastatic sites or do whole lung radiation at week, at the same time as local control, those patients are very unlikely to tolerate therapy after that.
Right. Next from Dr. Manas, do you skip radiation for any group of patient?
Do I skip radiation? All group 1 patients who have embryonal histology don't get radiation therapy. That's number 1. I have never irradiated vaginal rhabdomyosarcoma because the late effects are horrendous. And I haven't had I must have treated about 10 or 12 over the years. I don't have a single patient who's relapsed when I've treated them with higher dose cyclophosphamide. And so you monitor them serially with colposcopies and do biopsies. And this is another group where you delay radiation therapy as much as possible. And at week 27, my preference is, if the patient is not in CR by week 27, then I recommend a total hysterectomy, vaginal hysterectomy in those patients, because then you avoid radiation. Because can you imagine radiating a 2-year-old girl, would result in a frozen pelvis, in vaginal atresia, and it's really, and an ovarian failure, and that's quite horrendous. So that's one group of patients I absolutely do not radiate, and strongly recommend surgery if there is residual disease after about 27 weeks of therapy.
Great. The next question is regarding outside a clinical trial, what is the dose of cyclophosphamide in low risk, intermediate, and high risk?
So in low risk patients, and this is a little caveat, you really have to know the data. It's not as simple. If you are group 2 at a favorable site, then 4 cycles of VAC with lower dose cyclophosphamide, followed by 4 cycles of VA, has excellent outcomes provided you use radiation therapy. The second thing is, if you have group 3 disease, all lymph node involvement, even if it is excised, the best data is with D9602, which is similar to IRS4 regimen. That's higher dose cyclophosphamide. That's what I personally use. For not on clinical trial patients, if they are intermediate risk, I still use VAC with high dose cyclophosphamide because those are the best results. And for metastatic patients, I use VAC with high dose cyclophosphamide. Again, that is the best sort of published data, except in the group of fusion negative patients who have metastatic disease. It appears that the ARST 0431 regimen, which was the kitchen sink, which had vincristine, doxorubicin, cyclophosphamide, ifosfamide, etoposide, actinomycin, and irinotecan all in it, was exhausting therapy. Some of them were interval compression. Those patients actually had the best outcome. And those are embryonal patients less than the age of 10 with metastatic disease. But no one has done a head-to-head comparison with high-dose cyclophosphamide. And my bet is that they're probably similar. And that's why we include that group of patients as intermediate risk in COG. So that's broadly what I would do. Yeah.
From Dr. Juhi regarding omission of radiation to lung in a metastatic disease if the response to neoadjuvant chemo is good. Is it okay?
So I personally administer whole lung radiation at the end of therapy to all my lung metastatic patients, and many of them have that. It's still controversial. There was a paper by Leo Long from our radiation oncology group, which was published last year in JCO, which actually seems to suggest that whole lung radiation was beneficial to patients, particularly those who are in CR. I think the morbidity of 1,200 for a young child or 15 to 1,800 for an adolescent or higher is, especially if you have not treated them with doxorubicin, is actually very well tolerated and may be of benefit.
Great. So again, regarding high risk RMS, is VAC good enough or VDC alternating IE is better?
So not for high risk rhabdomyosarcoma, and high risk, I'm talking COG high risk, not the EPSSG high risk. Nothing which we've done has actually shown the benefit. And so I use the simplest regimen with the best data. Some people have already moved on and used the least toxic regimen. So they use lower dose cyclophosphamide because they feel that they're not going to cure these patients anyway and want to maximize quality of life. I haven't done that personally for my patients because we don't have prospective data on lower dose cyclophosphamide. And so I personally use VAC for those patients. But once we get the results of the 2031 study, which randomizes vinorelbine and cyclophosphamide, that is the first time in stage 4, group 4 patients with a poor prognosis, we will have prospective data which actually tells us whether it's acceptable or not. So if the outcomes are very similar, then I would use the lower dose cyclophosphamide. We just have to be a little patient. It's another 6 to 12 months away. But on the other hand, if the rate of progressive disease is much sooner, you need to have full disclosure to your patients. I mean, I think, and so supposing patients are progressing at 6 months instead of progressing at 18 months, that might sort of allow you to choose what's the best regimen. So I sort of never pretend to know the answers about everything. I mean, I really go with what the data shows and what we've learned when we take care of patients.
So we have a few more questions. Can we proceed if you have time?
Yeah, I'm happy to stay. It's still early in the morning over here,
Thank you. Thanks.
Okay, that's not a problem.
Regarding the timing of radiation in children less than 3 years with parameningeal rhabdo, with intracranial, without intracranial, like how do we?
So, I mean, less than 1 year age is a challenge. These patients without radiation therapy are going to relapse. I mean, for a patient with intracranial extension, I probably would recommend starting radiation at the same time as the other patients. Now, on the other hand, if it is fusion negative disease and it doesn't have a MyoD1 mutation, those patients, if the response is great, you could consider pushing radiation to week 18 and then adjust the chemotherapy accordingly. And that's what I would recommend. But if you don't irradiate a parameningeal patient, they will relapse.
Okay. So, next, regarding bladder prostate rhabdo,
Yes.
where surgery is usually suboptimal, would you intensify on chemo radiation case-to-case basis?
So the best results again in this group of patients is with high dose cyclophosphamide, and we use radiation therapy. If you have access to protons, that's really good. IMRT is also okay. For those with marginal resections up front, you could consider brachytherapy. There are a lot of publications from France, with that. The late effects have not been studied really well, and these patients tend to have a lot of sort of urological late effects. But the standard of care for unresected bladder, prostate, rhabdo is still chemotherapy and radiation therapy, and the best outcomes are with higher dose cyclophosphamide. And that's especially if it's fusion negative, those patients actually have a really good prognosis. I mean, they have an EFS of usually about 80% or higher. And in Europe, on the new classification, bladder and prostate is considered a favorable site. In the US, we still consider it an unfavorable site.
So next from Dr. Kalashekar, regarding the lower middle income setting, where we use COG approach in most centers, maintenance should be tested further? That has a role?
So in our experience over here, I showed you the data. The addition of maintenance therapy didn't seem to make a difference when we used lower dose cyclophosphamide in the intermediate risk, right? So I personally don't use it. There are some doctors who feel that based on the European data that they should use it. And we'll have the data based on the next clinical trial, which will take about 4 or 5 years to finish. So that's what I would say. I think the other thing, I don't know if Deepak Bansal's on. Is he on? So he's been working with me together with St. Jude, and very soon you are going to have the ARIA guide for the management of rhabdomyosarcoma, which will be useful for everyone. And there are pathways, whether based on the resources you have and whether you're in a low or middle income country or a high income country or at a center in a low or middle income country, which can deliver treatment just like a high dose therapy. And I think, I've really enjoyed working on that effort, and it's completely evidence based with a lot of practical points. And I think that would be very, very useful to you in India. I mean, and I think, if you're going to invite me to come to India to speak, I might be able to speak about that once that's published. I mean, because I'm really proud of that effort, that really international effort to put that together.
Next is a specific case scenario. A 2-year-old child with extremity mass, lung metastasis, good response to VAC regimen. When and what dose of radiation?
What's the histology and fusion status on that patient?
We'll maybe wait for the reply from.
It's embryonal histology. So this one, I would worry. Number one is with the 2 years old, do they have a P53 mutation and a germline mutation? This patient has an extremely high risk, as I mentioned, of having a cancer predisposition. But in general, I personally believe, you have to survive your first cancer in order to get a second cancer. And so I usually treat them effectively. If surgery can be done for the lower extremity primary with an R0 resection, and it's fusion negative, you can avoid radiation therapy to the lower extremity. And if the patient is in CR, my personal recommendation would be to give them 1200 of centigrade of whole lung radiation at the end of treatment.
Next from Dr. Purna Kulkure, ma'am.
Remember, we do, just a moment. We give patients with stage 4 Wilms tumor 1200 all the time, all right? And many of them are young. So it would be very similar morbidity to that. So I wouldn't worry too much about it. Sorry.
Okay. Regarding the special considerations for parameningel rhabdo, can we be?
So I sort of, if they're non-metastatic, they're all intermediate risk. I personally treat them all with vincristine, actinomycin, and 2.2 grams per meter squared of cyclophosphamide with 14 cycles of therapy, which is standard. I recommend starting radiation with the 5th cycle of chemotherapy. So concomitant with VAC, and we usually hold dactinomycin for the next 2 cycles because it usually takes about 6 weeks of therapy. I still at this time point recommend only 50.4 gray of radiation therapy. Our experiment where we escalated the dose to 59.4 for large tumors actually did not improve outcomes, and obviously the toxicity is significantly higher. And the last thing is, if you're able and have access, I would recommend proton beam radiation over IMRT if feasible, but otherwise IMRT is definitely recommended. Does that answer your question, Professor?
We'll wait for the reply. So next
Yeah,
question.
and I don't recommend upfront radiation in these patients because I think chemotherapy is more important, and almost all of them respond right away. And the last thing is, I mean, for staging, we recommend, a lumbar puncture. And to date, I don't have a single patient who's had leptomeningeal disease who has survived, and many of them die pretty rapidly. So that's one group of patients from the very beginning. I offer them palliative care if that's the case.
Next is regarding the minimum gap between actinum bar doxo and radiation.
So you can give doxorubicin and radiation concomitantly when you start radiation, and the next time you give them dactinomycin or radiation is when you're confident that they have almost recovered from the acute side effects of radiation. So usually in that case, it's when the acute skin toxicity or mucositis is resolved. Sometimes in some patients, um, uh, you may have to wait 3 or 4 weeks after radiation. Usually 3 weeks is complete. But in some patients, you can start right away after radiation is finished. It really depends on the site. The place where I've seen patients have the most trouble are usually the parameningeal sites or the pelvic abdominal sites. The extremity sites tend to do really well during radiation, and I wouldn't worry about them as much unless there's skin breakdown. But actually, in the majority of my patients, I've been able to start uh, actinomycin, or in a Ewing sarcoma patient, for example, doxorubicin, uh, uh, you know, within 2 to 3 weeks after radiation's finished. I know that the Wilms Tumor Committee had put out guidelines, which are not really, I mean, it is more out of tradition rather than anything, where they recommend, uh, decreasing the dose like for 6 weeks after. But uh, in practice for non-study patients, it's really, I mean, it's based on your experience, and I think they handle it reasonably well. It's the myelosuppression you worry about more, because when you do flank radiation or whole lung radiation, the amount of hematopoietic tissue which is radiated is really quite high, and I think that's the bigger challenge, to maintain dose intensity rather than worry about radiation recall injury.
The next is regarding the role of brachy in vaginal RMS.
So it's access. So brachytherapy definitely has a role. So in patients where there are marginal resections at difficult sites, if you have the capability and the expertise, you can definitely do that. So people do this for vaginal rhabdomyosarcoma and bladder rhabdomyosarcoma, bladder prostate, particularly in France, and Memorial does it, and some other centers do it. I know in India you have a lot of expertise in brachytherapy, and so so I think it's very reasonable to actually consider. But it's only for patients with marginal resections. If you have an R2 resection, it's of no use, in my opinion, and it's also more complicated. You have to be aware of the you know, the late effects also from brachytherapy. And as I shared with you earlier, personally to date, I have never had to use brachytherapy for vaginal patients. I've managed them all with higher dose cyclophosphamide and surgery if indicated. And really, it's only one of 12 patients whom we had to do a hysterectomy where it was still positive when the mass had not shrunk significantly. And that patient's alive and well and doing brilliantly today, almost 10 years out.
So regarding the early radiation in parameningeal, is there any role?
We don't recommend that anymore. I think getting chemotherapy in as fast as possible, even pending a diagnosis, is probably much more helpful than starting radiation therapy.
So next, in localized rhabdo of bladder prostate, would you go for complete removal?
We don't recommend that unless it's a very young patient where the side effects of radiation are unacceptable and the family is in agreement with a pelvic exentration. Most of those are not just bladder resections, they're pelvic exentrations, which are really big operations. And those were the operations which were done prior to higher dose cyclophosphamide being actually, most of those operations were done by Dan Hayes, who was the head of surgery at Children's Hospital Los Angeles. So our center had a lot of expertise with those surgeries. I reserve that for recurrent disease because the stakes are much higher. So if they have local progression and they've previously been radiated and the patient doesn't have metastatic disease at the time of relapse, that's the time I recommend a pelvic exentration. Because remember, you are basically committing these patients to an ileal conduit and a permanent ostomy later. And also, their very often their sexual function is compromised.
Another case of metastatic rhabdo who shows partial response to 4 cycles of neoadjuvant. Can we try with more cycles?
No. So the thing is, and there are numerous studies in the literature with this, it is not uncommon for you not to have a CR. So PR, or stable disease, is the most common response in rhabdomyosarcoma. And in the old days, people were really concerned about this and they went in and did these big surgeries. And in a large number of patients, they were maturing rhabdomyoblasts, a terminal rhabdomyoblasts. You can have patients with a residual mass 20 years after treatment and it doesn't do anything. It turns into stone, a scar tissue over time. So I wouldn't be worried. So in rhabdomyosarcoma, sometimes a little less is more. So I would only worry if the imaging characteristics are changing or the tumor is growing larger. Even then, we're going to have a couple of reports just going in. In one case, we were fooled where a patient had to come off a trial where the tumor was progressing rapidly, and that was a bladder prostate patient and had a pelvic exentration because of obstruction, and it showed proliferating rhabdomyoblasts. So you have to be a little careful. But if you have a worsening of enhancement on MRI and growth of the tumor, you would that will be a problem. We also have another paper coming out soon where maturing rhabdomyoblasts actually showed as really a very hot focus on a PET, and we were actually convinced it was going to be a relapse. And when we went in and resected it, and this is in a metastatic patient, it was all maturing rhabdomyoblasts, and this patient is now 1.5 years out after that surgery with fusion positive metastatic rhabdomyosarcoma. So you have to be a little careful and really take the entire context of the patient when you make these decisions. But I would start radiation therapy for the residual disease and continue chemotherapy according to the plan. I wouldn't we wouldn't stop chemotherapy after 4 cycles, right? Was that your question? Okay.
We can proceed to the next one. We have just 2-3 questions left. So,
I think, Vinod, we should really wind up. Dr. Leo has been really kind and has been answering questions for the last 30 minutes, which is amazing. So, let's wind it up quickly,
sure.
and really big thanks to
Yeah,
him
I
for.
can spend another 5 more minutes and then we
Okay.
can
All
the
right.
topic
Let's
here.
just wind up in 5 minutes, Vinod.
Yeah, brief response to the rest of the questions. Special considerations for spindle cell rhabdo in infants.
So the spindle cell rhabdo in infants are really favorable tumors. But in this day and age, I would make sure that they don't have uh, a MyoD1 fusion, because those have a poor prognosis, but those tend to occur in the head and neck, trunk, or extremity tumors. The spindle cell neoplasms which occur in the paratesticular region are the most favorable, and you don't have to worry about them. But there's this other entity which has a VGLF NCOA2 fusion. Those patients don't respond to chemotherapy, but have a very good prognosis if they can be surgically excised. There are very few reports of metastatic disease in the literature. So the devil's in the details with spindle cell rhabdomyosarcoma. But in general, they tend to be low risk patients unless they have a MyoD1 fusion.
Vinod, are you there? Let me ask the next question. Paratesticular RMS fusion negative in a 15-year-old male, upfront high inguinal orchidectomy done, and PET scan is negative. RPLND not done. Any role of radiotherapy?
Well, you don't have the data to give them, right? This patient would be at high risk. Is this a fusion negative patient?
Fusion negative paratesticular RMS, 15-year-old.
Yeah, so these patients have about a 30% occult chance of having metastases. This is sort of shared decision making based on the data. My preference would have been to confirm it. But if not, the patient is in CR and doing well. I guess you could consider dog leg ipsilateral radiation up to 3600 centigrade, to maximize outcomes. But I don't know if it is necessary or not because we don't have confirmation that he has it. But if you look at the IRS4 data, patients who were teenagers who did not have an RPLND, even with high dose cyclophosphamide, had an EFS of 63% compared to those who were under 10 years of age who had that. But a lot of it was driven by alveolar histology and then the age. So you could make a clinical decision based on that. But again, I usually go with what the data says.
Sure. A 3-year-old girl with retroperitoneal RMS with lung mets unresectable due to iliac vessel involvement. Good response to chemo after 4 cycles of VAC, 3 centimeter residual. Local site RT, any dose modification in a young girl.
So the radiation oncologists do this, right? So in a young girl, I would recommend a cone down radiation where you could consider a wider rate, especially if this patient didn't have an attempt at surgical resection. I think radiation oncologists fudge all the time on this. And so the area of residual disease should get the highest dose of radiation, but in the, but the broader field, you can compromise and give a lower dose or even potentially skip with the good response. I think the bigger challenge in this patient is really the pulmonary metastatic disease, because that's probably going to determine the ultimate outcome.
Thank you, Dr. Leo, for this amazing session. There are so many compliments in the group, and it really means a lot. You took so much time out for us here in PHO chapter, And, I don't have words to thank you. And please visit India. Please attend our annual conference. Next time, we are not going to take a no from you. And we hope you can club your holiday.
My life is planned 1 year in advance. So as much notice as possible would be really helpful.
I'll ask the PGI Chandigarh, Dr. Deepak Bansal, Dr. Amita Trehan to let you know the dates for the next FOCON, because our next year FOCON is in Chandigarh. So, you may want to come for that. I'll pass on the message to Dr. Bansal and Dr. Trehan. So thank you so much once again.
All right. It was my pleasure, and it's great to to do this session with you. I'm glad you found it useful.
Thank you.
Bye, everyone.
Take care. Thank you, Badira, for organizing this every month. So much of effort goes into organize these meetings, and we are really happy because we had almost 140 audience today, attending your session almost till 15 minutes past 8. So thank you once again. Thank you, Echo team, for giving the platform, and see you all at the midterm CME in Noida, on 1st, 2nd, and 3rd August. Our annual the midterm conference, and hope we all have a good academic time over there. Thank you, Dr. Leo, once again.
Bye-bye. Take care.